Hello and welcome back to Pharmacology with Dr. Sokolow. So today is the first lecture on pharmacology for endocrine disorders, and we are going to start with diabetes. So what is diabetes? Diabetes is a disorder of the carbohydrate metabolism. And there are two types of diabetes, as you probably know from your other classes in nursing. So the type 1 diabetes is the type that is related to a deficiency of insulin, and then type 2, it's a result of insulin deficiency and or resistant to the action of insulin. So it was considered to be the adult onset diabetes, but no, unfortunately, with an healthy habit, an healthy lifestyle, fast food diet, we see a lot of children with type 2 diabetes. So this is why when you compare the two, no, type 2 diabetes is not really considered as the adult onset. So type 1 diabetes represent about 5 to 10% of all cases, which is about 1 million American, and it's called the insulin-dependent diabetes mellitus. So those patients rely on insulin therapy. They would not survive if they don't use their insulin. This one is, usually occurs during the childhood, so it's called the juvenile onset. And the primary defect of and the primary cause of type 1 diabetes is the destruction of the pancreatic beta cells, so the cells that secrete the insulin. Usually it's the result of an autoimmune process. And in patients with diabetes type 1, the level of insulin is low in the early stage of the diabetes, but is totally absent later on. And so that's why they need to have supplement of insulin, because they cannot produce their own. Now, type 2 diabetes is the most prevalent form of diabetes in the United States. There's approximately 90 million Americans who are suffering of diabetes. It's called a non-insulin dependent diabetes because patients still produce their own insulin. It's just that they are deficient, their level can be low, and also the receptor to the insulin is resistant to the action of the insulin. Obesity is usually present, so as I mentioned, unhealthy lifestyle, junk food, obesity lead to type 2 diabetes. And so you have an insulin resistance and inappropriate insulin secretion. So in the case of type 2 diabetes, the level of insulin can be low. That would be the type of deficiency. But in most of the cases, the level of insulin is normal or high, but the cells are just resistant to the action of insulin. So this slide just summarize how insulin is synthesized and where it is synthesized. So its biosynthesis occur in the pancreatic B cells, so in the islet of Langerhans of the pancreas, and it's stimulated by an increase of blood glucose. So usually after a meal, the blood glucose increase, and then insulin is released to lower the blood glucose. And so first insulin is secreted as a proinsulin, and it has to be broken down into insulin, and then it's connected peptide. So this is the active form of insulin, and this is a peptide enzyme. This is why the therapeutic insulin has to be injected, because it is a peptide hormone, and it will not survive in the stomach if it would be given orally. So on this slide, this is a summary of the physiology of insulin, what is its action on the glucose storage and metabolism. So insulin has a metabolic action, and overall it's an anabolic effect, so that means the constructive part of the metabolism. And insulin can also promote cell growth and division. So here you see once insulin is secreted, it's going to stimulate the liver to store glucose in the form of glycogen. So this is the green arrow means the action of insulin. Then insulin would also promote the synthesis of fatty acid in the liver and increase the triglyceride synthesis. Another action of insulin is to facilitate the entry of glucose into the muscles. So you see here, facilitate the uptake of glucose into the muscles, and also facilitate the uptake of glucose into the adipocyte. In the muscle, insulin will promote the glucose oxidation, so the glycolysis, and stimulate the formation of pyruvate and the synthesis of amino acid and protein. And then in the adipocyte, it inhibits the breakdown of fat in the adipose tissue. So that's why it's in red, because it's an inhibition. So now, what are the symptoms of diabetes? So you probably know that from your med-surg course. So these symptoms are more predominant in type 1 diabetes, when patients start developing type 1 diabetes. So hyperglycemia, of course, if the patient is diabetic, so the first thing you want to check is the level of sugar in the blood, so hyperglycemia. And then you have the 3P, polyuria, polydipsia, and polyphagia. So which means they are eating too much, and here they pass an abnormal amount of urine, and in this case they would ingest abnormally large amount of fluid by mouth. And so these are kind of like the sign and symptoms: thirsty, feeling tired, passing more urine, and feeling unwell. Weight loss also can be seen in type 1 diabetes. Now, for patients with type 2 diabetes, this may be different. Those you may not see those symptoms. So the only thing that we will notice is the high sugar level, and so that's why sometimes it's diagnosed late. It's because they don't have those other symptoms. So how is diabetes diagnosed? So the diagnostic of course is to measure excessive plasma glucose, and in order to make the diagnostic, the patient must be tested on 2 separate days, and both tests must be positive. So it can be one of those 3. They can do the same test on 2 different days, or 2 different tests, but those 2 test result has to be above those values. So it can be either a fasting plasma glucose, and in that case, if the plasma glucose is over 126 milligram per deciliter, that would be a red flag. And then if they do a casual plasma glucose, so they're not fasting, if the value turns out to be over 200 milligram per deciliter, that's also a red flag. And if they have those 2 combined on 2 different days, then the patient is diagnosed with diabetes. And then the third test, it's an oral glucose tolerance, so it's a 2-hour plasma glucose. So the level will be measured 2 hours after ingesting a solution that is rich in glucose. You see that contains 70 milligram of glucose, and again, the value are over 200 milligram per deciliters. This is a red flag, and so one of those 3 diagnosis has to be repeated and has to be above the normal value to be diagnosed as diabetic. So another value that is commonly used is the A1C, so the glycated hemoglobin, which is an average of over 3 months. And so this is kind of more accurate nowadays because patient who knows that they have to do their as their blood drawn, they would maybe fast and eat well and healthier for a couple of days. And so when they do their test, it all turns out to be normal. But with the A1C, it's really hard to cheat unless, they're really healthy and compliant for 3 months, then the A1C will be lower. And this is, what we want. We want to see an A1C going down, especially if they are pre-diabetic. But so the A1C value, like the threshold to be diagnosed as diabetes, is above 6.5%. Now, the treatment of diabetes, first of all, it depends which type of diabetes it is. And if the patient is obese, of course, diet and exercise is something that is very important to initiate, to help reduce the plasma glucose. Now, in patients with type 1 diabetes, usually they are not overweight and they may be on the lower side, and for them it would be to maintain the weight in those patients. Now, insulin replacement, so it's going to depend on also on which type of diabetes. So in patients with type 1 diabetes, their survival requires daily insulin therapy. So all patients with type 1 are receiving insulin therapy. Now, some patients with type 2, if it's more advanced, depending on their plasma glucose level and their A1C, they may require to have supplement of insulin on top of their oral hypoglycemic drug. Now, oral hypoglycemic drug, it's only for type 2 diabetes because the patient needs to be able to secrete insulin. So it's not for type 1 diabetic patient. Now, there are some new injectable hypoglycemic drug, and we'll talk about those. And then lastly, so in case of insulin overdose, glucagon is the enzyme that has opposite effects. So this one is an hyperglycemic hormone, and that would be given in case of insulin overdose, which means if the patient had taken too much insulin and they become hypoglycemic, severely hypoglycemic, then glucagon will help restore the plasma glucose level. So what are the treatment goals? So first of all, you have the plasma glucose level, and then second, you have the glycated hemoglobin. And for self-monitoring blood glucose, the American Diabetes Association has written the following guideline in 2015, which recommend a target values between 80 and 100 milligram per deciliter before meals, and lower than 180 milligram per deciliter postprandial. It used to be 70, but they review it to 80 milligram per deciliter. And now for the glycated hemoglobin, so the A1C, which, as I mentioned earlier, provide an average glucose level over an extended period of time. So basically it's during the lifespan of red blood cells, which is about 120 days. And so the ADA guideline is that the A1C should be measured twice a year and that the target value should be lower than 7%. So what are the complications of diabetes? So you have the short-term and the long-term complication. Short-term complications are primarily seen in type 1 diabetes, but you can also sometime, in severe type 2 diabetes, you can see that. You have hyperglycemia. So if if their insulin dosage is insufficient. So, at the beginning they have to adjust their dosing of insulin, so they can cause hyperkalemia. Now you have ketoacidosis. This is a potentially fatal complication when hyperkalemia persists, and I have a slide that I will explain in more detail. But if the patient doesn't take his insulin like they are supposed to do it, or unfortunately because the cost of insulin is not cheap in the United States, some patients will skip doses, and then that can be a complication of diabetes, but also for not being compliant with their insulin. Now, hypoglycemia is the opposite. It's like if they are using too much insulin or too much of their hypoglycemic agent, especially we're going to see that some patients need to have more than one hypoglycemic agent, and so the combination of those agents will, all lowering the plasma glucose, and so that can cause hypoglycemia. Now, the long-term complication is actually responsible for 90% of the diabetic death. And you have the microvascular damage, such as cardiovascular disease, hypertension, stroke, MI. And then the microvascular damage, which once they are there, they are irreversible. And so one of them is retinopathy, and then you have that would lead to blindness. And then you have nephropathy that causes chronic kidney disease, sensory motor neuropathy. So the patient will no longer sense their extremities, and that can lead to amputation of the foot. Then you have the autonomic neuropathy that can cause gastroparesia, and then erectile dysfunction. Now, as I said, patients who would not take their insulin replacement, in diabetic type 1 patient who don't take their insulin therapy can result in diabetic ketoacidosis. So insulin deficiency will lead in altered fat metabolism and altered glucose metabolism. It will increase the lipolysis, and that results in increase of free fatty acid. Those free fatty acids will then be oxidated into keto acid, and that leads to the formation of ketose body and ketosis that cause vomiting. And then on the other side, the altered glucose metabolism leads to an increased glucose production and reduced glucose uptake. That leads to hyperglycemia, not kalemia, and then which result of glycosuria, osmotic diuresis. So you have an increased loss of water, increased diuresis, and then you will lose sodium and potassium in the urine. This, in combination with the ketosis, will cause dehydration, and then hemoconcentration, and then the accumulation of ketone body would cause ketoacidosis, and then ultimately result in shock. And if it's not treated on time, this is an emergency situation, and if it's not treated on time, that can lead to death. So this is definitely a life-threatening emergency, and so as I mentioned on the previous slide, it's characterized by ketoacidosis, so which leads to acidosis, hyperglycemia, glycosuria, dehydration, and coma. The treatment is to give insulin IV ASAP, so insulin replacement, so to restore the glucose level to a normal level. And then you want to treat the dehydration and the loss of electrolyte with water, sodium, and potassium. And so you may have heard about the death of Casey Johnson, who is the heiress of Johnson & Johnson Pharmaceutic. She was found dead in her apartment in Los Angeles, and she was diabetic. And so the coroner, after doing the autopsy, found that she died of diabetic ketoacidosis, which is, pretty sad because this is something that can be avoided if you are compliant with your insulin therapy. And that's it for the first module. And I will talk to you soon in the insulin replacement therapy and the oral hypoglycemic agent.